then it will progress to the full stage of illness. So that's when everything will be manifested. So if I have chicken pox, I will have all of my lovely sores, okay? And I'm not feeling good, okay? So I have the full gamut of symptoms of whatever that disease is. And then if I can make it through the full stage of illness with whatever treatment is prescribed, then I will progress to the convalescent period. And convalescent, if you just see that word means recovery. You're convalescent, you are recovering from the infection. So, just as a little example, we're gonna show you what two types of wounds look like. A wound is a wound, right? It's a break in the skin. So here is a healthy wound. And bless you. And here is an infected wound. Okay? So now look at the difference between the two wounds, right? The healthy wound, I can still see it's there, but there's an absence of pus, there's an absence of drainage, there's an absence of redness, and the edges of this wound are what we call well approximated. They're attached, okay? They're very, very close. Okay? And then if you look at an infected wound, okay, you see how it's open, it's draining, lots of pus. The area around the incisional site is very red, swollen, tender. If it's near any lymphatics, you will see like a red streak following the lymph all the way up the area of the wound. And clearly there's a big difference. Now with a healthy wound, it's gonna be sore, it's gonna be tender, but the patient really shouldn't have pain. With an infected wound, because of the redness, tenderness, and swelling, there's gonna be pain, okay? The gradations of pain, obviously, are going to be subjected to the patient, but there is going to be discomfort. And if this is a bad enough infection, there could potentially be a loss of function of wherever that infection is. So if it's on my finger, maybe my finger is so red and so swollen and so draining with pus that I can't bend it. Okay, so there's a loss of function. Depends on how bad the infection is. So again, the nosocomial or healthcare associated infections are classified and considered as something that the patient gets while they're in the facility during the normal course of their health care. And it may manifest or show itself with signs and symptoms way after they are discharged. So is this something that could potentially bring a patient back to the hospital? It can. It absolutely can, right? If my patient was exposed to C. diff, but they didn't start having any GI symptoms until 3 or 4 days post-discharge, would that be something that could potentially bring them back to the emergency room? Yes. And if they come back to the emergency room and they do a stool culture and they find C. diff in the stool and they look to see that the patient was recently discharged from a healthcare facility, they will make the assumption that they acquired it in the healthcare facility. Okay, because that's not something that you just get, okay? It takes a while, there's a prodromal stage before you manifest. That's why we're sending folks home earlier rather than keeping them in the hospital, because we don't want them to get HAIs. The longer you stay in a hospital facility, the greater your chances of picking up a nosocomial infection.
Yeah.
So that, again, is one of the reasons why we send people home early. So again, these are things that we monitor and you will hear about when you go and rotate in your clinical areas, in your upper courses. Catheter-associated urinary tract infections, or CAUTIs. That's the acronym. So what does that mean? That means that a patient, say for example, has an indwelling Foley catheter. That's a catheter that sits in the bladder and the urine just drains out and collects in a bag. We used to put Foley catheters in patients all the time. And then what happened? Then we started not taking care of these Foley catheters. We were not cleaning them properly. So what happened? Bacteria would get on the tube, and because the tube was sitting inside the body, the bacteria would migrate inside the bladder, and poof, you have a CAUTI, a catheter-associated urinary tract infection. So in other words, if I did not have a Foley catheter in the patient's bladder, chances are they would not get a UTI, right? Does that make sense?
Yes.
So now, because of the evidence-based studies that have been done, we only put indwelling Foley catheters in patients that absolutely need it. So say the patient was going for surgery and I had to measure the I&O and we did some bowel surgery, so I wanted to keep the bladder decompressed for the patient's comfort, whatever. Okay, post-op surgical day 1, when they do all their rounding and they're talking, the question will be asked, does the patient still need a Foley catheter? They ask the question every day, because the less invasive things that are in patients, the better off they are. So as soon as they say, no, we can take it out, we take it out. So it is something that is on our radar screen. This type of infection needs to be reported, okay? So hospitals don't like to report things.
Reportable.
It's a reportable, yeah. It's a reportable. Another hospital-acquired infection or nosocomial infection is a surgical site infection, or an SSI. So what does that mean? If a patient goes in for any type of surgery, okay, that surgery site, that wound, that dressing is monitored very, very carefully. And if it requires a sterile dressing change, oh, we better keep it sterile. Because if it's sterile dressing and they get an infection, what does that mean? We didn't keep it sterile. Yeah, we didn't keep it sterile. Another one is a CLABSI, or a central line associated bloodstream infection. This is when our patients have deep central lines. Maybe they are required to get chemotherapy. Maybe they have long-term infusions. They need weeks and months of antibiotics. We're not just going to put a peripheral IV in them because it's not going to last for months. So we put deep lines in them. So the deeper the line, the higher the risk of an infection, right? Because it's a direct path right into their bloodstream. So that is monitored very carefully. And when the patient doesn't need it, we definitely remove it. And the other example is a VAP, or a ventilator-associated pneumonia. Because a patient might be dependent on a ventilator, a machine that breathes for them, if they have a tube in their mouth or a trach, that is a direct entry for pneumococcus to get into the lungs and cause pneumonia. So we need to be mindful of that, which means using good technique. So these are just some examples, you don't have to memorize them, but you will absolutely see them when you go to the hospitals. And people talk about cowdiness, what's your cowdy rate, how many cowdies did you have this month, how many did you have this year, did you have any SSIs if you're a surgical floor, right? How many SSIs, who had it, what was the occurrence? So they really do a deep dive into each patient that suffers from any of these hospital-acquired infections, because if it's something that the staff is doing, we need to correct the behavior so that it doesn't happen, okay? Otherwise, they would be out of control.
Give you like question. For example, if we have a SSI, like surgical site, which was ordered by doctor not to be opened, for example, for 4 or 5 days, the dressing shouldn't be changed, and patient develops infected wound, and I'm not allowed to change it because order states it. How it can be then acquired? It goes to the doctor, or it goes to the doctor, yeah? Just to make sure, because sometimes there is the orders.
Absolutely. Okay, so when we practice asepsis, okay, everything that we do is to prevent transmission and further spread of the bacteria. And why do we do that? Because that is a way for us to break the chain of infection. So we talked about medical asepsis, which is clean technique, and we talked about surgical, which is anything invasive. So that would be considered sterile technique. So if I'm putting in a peripheral IV in a patient, am I using sterile or medical asepsis?
Sterile.
Sterile, absolutely. And if I'm giving an injection?
Sterile.
Sterile, of course, absolutely. Okay. So, again, keeping everything either clean or sterile, okay? We've said it over and over and over again. So any surgical procedure that's done in the operating room environment, the labor and delivery environment, you want to make sure that it is eradicated of all types of pathogens, because the patient is exposed and open and it can get in them very, very easily. Okay. So we talked about hand hygiene, so I know I'll say it and beat it to death, but obviously you understand the importance of good hand hygiene.
Question. So on the reverse side, if the nurse itself has a wound or like a cut, small cut in her hand, does she work or stay like wearing the steriles all day long?
Well, it depends what the wound is.
Let's say her hand, like,
Okay, so she would bandage her hand.
and that's enough,
And wear gloves, of course.
all day long. That should be where.
Oh, yeah.
All day.
And how about the washing hand and wiping
You still have to wash your hands.
with the wound?
Oh, depends, like I said, what kind of a wound it is. How, is it a paper cut, or did you cut the tip of your finger off? I mean, there's a big difference, right? Everybody's got little micro cuts on
The
their
micro cuts,
hands.
they feel like the paper cuts, but
Yeah,
if you
paper
cut-
cuts, but if it's a
you can-
bad wound, I mean, it depends what kind of nursing you're doing, and you're in and out of patients' rooms washing your hands, you might not be able to work. You might not even be able to work, it depends. You know, everything has to be taken
Just take one.
on an but for sure, you gotta be careful. Listen, back in the day, when we were suctioning patients, we were not even using gloves, okay? And many, many nurses got a fungus on their thumb that was used to hold and break the suction so that we can suck out the secretions, because all the secretions would go right past the nurse's skin. And if they had a micro cut on their thumb, which, like I said, we do just in the course of our day-to-day, they would get a fungus. Yeah. So you gotta just be careful. So these are just a couple of little tips for you, 5 moments of hand hygiene.
Professor, when you're
Uh-huh.
doing secretion,
You also wear mask? Or
Yeah, I
just-
do. I do, because it's in the air, yes.
Oh.
So, hand hygiene, moment one, before you touch a patient, okay, you wanna do hand hygiene. Before a clean or an aseptic procedure, you always wanna do your hand hygiene. Certainly after any type of fluid exposure, whether or not you're wearing gloves, of course you're gonna do hand hygiene. After touching the patient and after touching anything in the patient's surroundings, because you do not want to spread it to other folks. PPE, you know how to put on PPE, you know the order for PPE? Okay, that's this, all this is just a reminder for you. Putting on PPE is not something that you should rush, okay? Put it on properly, because if you don't and you go in the room, you run the risk of exposing yourself and getting contaminated. So you have to make sure you take your time and do it the correct way. Removing it, the same thing. You're going to see people step away from the patient and just rip everything off. That is so wrong. That is just so wrong. Doctors will do it all the time, they'll just rip everything off, because you're just flinging everything into the air, okay? So that practice needs to be corrected, so that it's not done that way. Standard precautions, know this, okay? What is a standard precaution? What is it? We do this for every person, okay, that we take care of. Whether they're here for 5 minutes, for a blood pressure check, or they're coming to stay with us for a few days for a surgical procedure, okay? Standard precautions, okay, we use it on every single person that we come in contact with. And why do we do it?
Protect ourselves and the patients.
Exactly. So we approach every patient as if they may have a transmissible disease. So if we're coming in contact with any blood, any body fluids, any secretions, any excretions, we are going to use what? Gloves.
Professor, I have a question.
And if we need more PPE, we will do that as well, but absolutely, you're gonna use standard precautions. Yeah,
So, for standard precaution, let's say for example, I have a patient who does have one of the diseases that can be transmitted by contact. And I'm not aware, or maybe by, airborne or droplet, and I don't know. So how do I protect myself? Because I don't see anything on the patient, it's not showing any symptoms.
then you, at the
And I just have to take blood pressure.
the minimum you would use would be standard
Would be standard all the
precautions.
time, yeah.
And just give the disease.
Until you knew, until you knew, I mean, how would you know?
That's the problem, right?
That is the problem. That is definitely the
So
problem.
why they don't have like all nurses wear masks, gloves all
Well,
the
you
time
can't
and
be-
that's it?
You can't be walking around in a gas mask and PPE all day.
All
long.
day.
You
You'd be
can't do
frustrated
that, so
yourself.
we use the standard, okay?
Yeah.
But depending on what's going on with your patient, okay, so here, if you knew that your patient had a transmission-based type of illness that was either airborne, droplet, or something with contact, then you would use this in addition to your standard. So there's always a minimal amount of precaution that you wanna enact on yourself, correct?
Right, yeah.
Professor,
Yeah.
what about this stethoscope, like you put it from skin to skin, from patient to patient?
You clean it.
How do you clean?
Alcohol.
Just alcohol, that's fine.
Alcohol, yes.
You wanna
So
wash it?
these are some examples.
No, but I thought
of signs that
Maybe
you
do some-
might see in a hospital, okay? In the event that a patient had some type of a transmission-based disease. So airborne precautions, okay, there's a big stop sign, they make these signs very colorful, so you really can't miss it, okay? It's right outside the patient's door, and if the door needs to be closed, it will be closed, okay? So airborne precautions, they're gonna tell you everything you need to wear, okay? Droplet precautions, they're gonna tell you everything you need to wear, and contact precautions, they're gonna tell you everything that you need to wear before you provide care for the patient, okay? So all of this is based on the CDC, and the guidelines are very, very specific. And as long as you read the sign, and there's usually, in a hospital setting at least, there's a yellow cart that's right outside the door, and it has all
All
the
the-
equipment that you
Yeah, that you
need
need to get it.
before you go in the room,
Mhm.
right? Absolutely, absolutely. Okay. So, these are just some examples, okay, of what you can wear depending on what is going on with your patient. So, what do we do as nurses when we are caring for our patients? What is the process? Always assess, okay? We assess by observation, okay? We assess by asking the patient questions, part of the nursing history intake, okay? You're going to ask questions, gather all of the data, and from all of these cues, you're going to make an inference, okay? You're going to decide something. So this is all the assessment phase, and you know we assess all day long, right? When you went into the, nursing home, did you assess anybody?
No, yeah.
Not yet, you didn't do it yet? Okay, so hopefully you'll do it this week. You'll get a patient and you'll start with your assessment process. So you take a history of the patient, okay? You say, okay, what's going on with the patient? What had gone on with the patient? What's currently going on with the patient? And is the patient at risk for anything based on what history they tell you or history that you gather? Then, of course, you do your head to toe, your physical assessment, which is your head to toe, right? That's your own exam. And then you're gonna come up with a priority problem, right? Or a nursing diagnosis. This follows your assessment. First you assess, then you decide what your priority issue is or your nursing diagnosis. So in this case, is the patient at risk for an infection? Does the patient have an infection? Is there something actively going on? That's what you would decide. Then, depending on what you decide, you make a plan, right? Is that not part of the process? We
Yeah.
make a plan. So part of the plan is making some type of a goal statement, okay? If the patient is at risk for an infection, what could my plan be if they're at risk? You want to prevent them from getting the actual infection, right? If their risk is high, you want to plan something that prevents the patient from getting an infection. Versus, what if the patient has an infection? The plan is gonna be to prevent the spread.
And treat it.
And of course, treat it, yes. So plan is gonna be based off of what you have assessed and diagnosed. Implementation. What do we mean by implementation?
Treatment that is going to be done on.
Yes, what are the actual steps that we're going to do to either treat the patient or mitigate the risk and prevent the patient from getting the infection? So some things might be monitoring their vital signs, watching their lab values, changing their diet, incorporating some type of hand hygiene or bathing routine, right? All of the things that we know to control either the infectious process or prevent it from happening. The physician teams or the advanced practice teams would do what? They might order antibiotics, culture the wound, culture the blood, see what's growing, and then this way they know how to treat it. They would write orders for us if the patient had a wound. How do we clean the wound? What do we clean the wound? Are we doing a dry dressing? Are we doing a wet to dry dressing? Are we using a certain medication in the wound, right? All of that would be decided by our colleagues. And then, after we do all of that, we evaluate what we did. So we say, did what we do help the patient? Okay. Did the patient get better if they had an active infection? Or if the patient was at risk for infection, did the patient remain infection-free? So if we are doing the right thing and we have met our goal, then we keep doing what we're doing, because we're doing the right thing, right? We're giving the antibiotics, we're treating the wound, we're improving the nutrition, we're increasing activity, whatever the actual steps are. Now, what if we're not meeting our goal? What if the patient was at risk?
Go back and
infection?
reassess.
Yes. If our patient was at risk for infection and we could not keep our patient infection-free, we have to go back to the very beginning and figure out something new. So we go back and reassess. Okay? Look at what we did. If what I did was not effective, I need to change it. Okay, so that's what we mean by the nursing process. We reevaluate, reassess, replan, reintervene. Everything is in a constant state of motion. Because we always want to do what? Restore our patient to optimal level of health and well-being and let them go live their best life, okay? If we can't do that, we need to revisit what it is that we are doing so that we can change it. Does that make sense? Okay. So, hygiene, let's talk a little bit about hygiene, okay? You're gonna have this lab next week. Why is hygiene important?
Prevent infection.
Prevent infection, okay? So, helping our patient with hygiene, helping our patient with a bed bath, helping our patient in the shower. We want to assess our patient. Is our patient able to do their own hygiene and meet their own hygiene needs? Can they get up? Can they take a shower and wash themselves okay? Or do they need some help? They could be considered partial. Maybe they can wash parts of their body, but they can't reach other parts. So we would help them. Or are they incomplete? Meaning they can't do anything for themselves, maybe they're comatose, maybe they're paralyzed, something else is going on, so we have to do everything for them. So all of that hygiene is to maintain cleanliness, maintain their mental well-being, keep the skin intact, and therefore prevent infection. So it's not just the body, we also wanna take care of the hair, we wanna take care of the nails, we wanna take care of the nose, and a very, very, very big part is the mouth. Okay, the human mouth is full of germs. Okay? So if our patient is not able to brush their teeth, or what if our patient is NPO? What if our patient is fed through an NG tube or a PEG tube, and they're not using their mouth for eating A lot of nurses forget that the mouth exists. And they don't. You have to clean the mouth, okay? You always have to clean the mouth, because if bacteria form in the mouth, especially when the patient swallows it, and inevitably they will swallow their own saliva, all of that bacteria spreads through the body and the patient can become septic. Okay, so you want to make sure that you don't forget about that part of the body.
Do patient is in a high risk to have a pneumonia from not cleaning, not giving proper oral hygiene?
Everything.
It's one of the causes.
It could be.
If the patient is not.
Anything could be, any type of bacteria or pathogen, absolutely, absolutely. So these are some factors that can potentially influence an individual's tendency to be a little more fastidious with their hygienic practices versus not. Culture, okay, some cultures, believe in, very strict hygiene, others not so much. The environment, does the patient have access to, hygienic products so that they can clean themselves? Think of the undomiciled person that lives on the street. Okay, maybe they want to be clean, but they don't have access to it, okay? So that can influence as to whether or not they practice good hygiene. Also, the stages of development. Do you think babies and small children understand the importance of hygiene? No. What about the very, very elderly patient? No. Exactly, exactly. So they may need to be spoken to, guided to, so that they can maintain good hygiene and prevent infection. And also the state of their own well-being. If you are really sick and laid up in bed, are you gonna wanna get up and take a shower? No. No. You're gonna be too weak, too tired, right? Okay, but again, it is important, okay? So we talked about culture, and some cultures place a high level on hygienic practices, others not so much. So be mindful of your culture. Some cultures may practice good hygiene, but they don't use deodorant. So even though they're clean, as soon as they start sweating, you're gonna smell the body odor, okay, because of the bacteria. So that can be offensive to people that are not used to that, okay? So kind of be mindful of that as well. We talked about the environment, and we talked about stages of development. Okay, so you all know that skin is what? Skin is the first line of defense in protecting us from any types of microorganisms. What else does skin do? It's the
Homeostasis?
largest organ in the body.
Homeostasis?
Temperature regulation, absolutely, right? If it's a hot day and we sweat, what's the purpose of sweat?
To release
To
the
cool the body.
body.
To cool the body, right? That's why we sweat. What happens to somebody that gets heat stroke? If they're exposed to very high temperatures and they're not hydrated, they can get heat stroke. What happens? The body shuts down. It's no longer able to sweat because there's not enough volume. So you literally kind of fry. Okay, you get heat stroke. So skin is very important with regulating our body temperature. It also secretes a substance called sebum, okay, which is an oily substance that helps to lubricate our skin naturally. So you know how sometimes in the winter when you're exposed to the elements, then you come in the house and it's hot, you go outside and you get the wind burn and the cold, your skin gets dry? Okay, that's because the environment is creating such that you can't excrete enough of your normal lubricant, and we look to, external products to help, lubricate and soften our skin. Now, what happens to the elderly person? They no longer can produce this substance, so their skin is super dry. Super dry. So we have to be mindful, they may not be showered every single day. You'll see when you go into the facilities. They get bathed and cleaned, but they may only get showered once or twice a week because of the condition of their skin. So they may be on a shower schedule, okay? So just kind of keep an eye out for that. And what else does skin do? It has many nerve endings. So we feel things, okay? We feel even very light touches. We feel pain. We are very sensitized to gradations of temperature, gradations of pressure. So we feel all of that with our skin. And of course, the skin helps us to absorb our vitamin D, which we say, what? Everybody should go outside.
Part of immune.
Yeah, it's part of your immune system, that's right. Get some vitamin D from the sun, right? Go out and enjoy 15 minutes of sunlight at least once a day. Don't stay inside all day. Get some vitamin D. Okay, so some terms: AM care, PM care, PRN. We'll do this next week when we do hygiene in the lab. But AM is morning. Okay. Anti-meridian is, for those of you who really want to know the Latin derivatives. A lot of abbreviations in medicine are from Latin. So AM is ante-meridian before midday. PM is post-meridian after midday. And PRN is as needed, right? Whenever you feel the patient needs to be freshened up. So these are some of the purposes of bathing. Obviously, you know that everybody feels good. You promote circulation. So we'll teach you next week, and know this: when somebody is being bathed, we use nice long strokes. When we're washing them, we go from the periphery up to the core. And why do we do that? Well, it's not a frying pan, we're not scrubbing, right? We're not patting, that's not a wash. We're doing long strokes with our towel, right? Legs to the chest, arms to the core. Why do I do that? Yes.
Bring the blood back.
Beautiful. I am promoting circulation, right? I am promoting venous return. So when you bathe the patient, you use those long strokes, okay? That's important. And then, of course, does everybody appreciate being clean?
Yes.
Absolutely, 100%. Even the most confused patient, you give them a beautiful bed bath, they're nice and relaxed afterwards. Everybody likes to be clean. And it's good for them, their well-being mentally. And you can also use the opportunity to do active or passive range of motion when you're bathing somebody, right? You can also use the opportunity to do another skin assessment when you're turning them, right, to wash their back. And you can also use the opportunity to listen to lung sounds, okay, because you're right there. So even though you can sort of ask the nurse's aide or the CNA to bathe your patients, you should not give up this task 100%. The aide can go in and start to set up the patient, but then you go in and you help, okay? Because you're the nurse and you're using that time to assess your patient, okay? So don't always give all of the care, physical care, to the aide, because at the end of the day, as a nurse, you are still responsible, okay? So that's super important to know. And of course, you're always providing privacy, right? Always, always. So we'll go over most of this next week in lab. This is easy. This is no biggie. Mouth care, I told you, don't forget about that. And foot care, bathroom, we'll go over that. Okay, TEDS we talked about yesterday. Okay, so TEDS are good for what? Preventing DVTs and promoting venous return, right? Same reason why we did long strokes when we gave to a patient. And we're either using TEDS or if we're fancy, we're using the sequential compression device, but it works the same. And of course, we're always assessing. Assessing. We do that all the time. More assessment, okay. What are we looking for? Mainly it's the skin, the condition of the skin, any abnormalities in the skin, and of course the hair and the mucous membranes, okay. Now we diagnose if there's anything untoward or if there is a deviation from the norm. Does the patient have an actual problem? For example, they can't wash themselves. They have a self-care deficit, okay? That is a very good nursing problem, okay? Priority issue, my patient can only wash their hands and their face. Patient has a self-care deficit. Patient will need some help, okay? As opposed to they're at risk for something. My patient is recuperating from hip surgery, so they are at risk for impaired skin integrity related to the dressing, okay, where they put the prosthesis, right? So you can do either or. Are you getting me here? Yes? Awesome. Very good. Okay. Then, depending on whether it's an actual problem or a risk for a problem, you do your planning. Okay, what are the goals? What are we doing? How are we getting this patient back to their optimal state of wellness? And then we do the actual implementation. Yes?
How would you wash the materials?
You would still wash them, you would
But you
just
would
avoid that area. Oh, they're not letting you near that. Super tender. Super painful. That will hurt for 9 months after it heals. Because it's nerve pain. So nerve pain goes deep.
So how far away would you wash from the patient?
They'll let you know. Oh, they'll let you know. Trust me, they'll let you know. So that's enough. Yeah, it's a bad thing to have. Okay, so we do the actual steps, okay? Our nursing implementation, and then we evaluate. So you see, whatever is going on with your patient, you're still going through the process. Okay? You assess the patient, you diagnose the patient, you come up with a priority issue, you set goals, you implement, and you evaluate. Bless you, it's true. Any questions on this? Okay, good. If you think of any, you let me know. Let's go quickly back to what we were doing yesterday with our case study. Did you guys get a chance to read it? Did you look at it? Yes, no? Okay, so let's do it together. We have a few minutes. How many minutes do we have?
30.
We have 10. We can do this.
Oh, we finish. We can get 20. We have time.
20. 12:20?
Yeah.
Oh, we have 19 minutes. Okay, so let's do it together. I'll ask for volunteers. You are a nurse in a medical surgical unit in a hospital caring for a 68-year-old brick mason who returned to your floor after surgery to repair both knees 2 days ago. The surgery went smoothly and you are responsible for his post-operative care. What activity assessments are instrumental to determine the best method to transfer this patient from a bed to a chair? So what do we want to do? this is your patient, let's do some critical thinking. Come on, don't be afraid to tell me a
We wanna see how
suggestion.
best we can probably move the leg, or, because if you're gonna move him from bed to the chair, you have to see if he can bear weight on it.
Beautiful, so what is the patient capable of doing? Okay, how do we know that? Assess,
Assess.
absolutely, very good. What else do we wanna do? Is there pain or discomfort? Because we
Yes.
need to address that, right? Your patient is not gonna be cooperative with any intervention that you do if they're in pain. That's very understandable.
Check the surgical, you know,
Say again?
check the incision of the surgeon, with the surgeon. Incision?
Okay, you definitely wanna assess that, absolutely.
First of all, I'm gonna see if the patient is allowed to stand on their legs. Sometimes it says non-weight bearing bilateral.
Very good,
Or, or as tolerated.
right.
First, I'm gonna pay attention.
So
I am
what
able-
is the doctor allowing the patient to do? Because that will determine how we're gonna move that patient.
Cause it's both knees, so,
Both knees.
yeah. so-
Okay, so they may need an assisted device.
Yeah.
Right? Something to lean on, maybe the doctor doesn't want them doing 100% weight bearing, okay? So that is something, that is part of what we will find out, that's our assessment.
Then I'm gonna ask the patient and I'm gonna see his pain tolerance. How, does she or he can stand actually. Is it
Okay.
partial weight bearing?
What about,
If yes, I'm gonna proceed with, his tolerance is good. If he's in a pain, I'm gonna give him pain medication prior to transferring the patient. If he's in a really pain and pain medication not working, I'm gonna use not a walker, any lift devices, which I'm allowed to use. If it's, I can do it with, 2 people and a walker, I can do that. It depends on the situation.
okay, it absolutely depends on the situation.
Assess if the patient is able to help during the transfer or
Yes.
not, or if it's.
Yes, so does the patient understand what it is that you want to do? Right, because remember, there has to be communication between yourself and the patient. So the patient needs to be able to understand what it is that you want to do to help them. And you also need to assess, is your patient going to be cooperative? Or are they gonna say, no, I'm not doing it, so.
Or if he even able to, like, cause he
Well,
had a new
that's
surgery,
you're
yeah.
assessing that,
Right.
right, you're assessing that, but you need to understand, does your patient understand
Right.
what you're trying to do? So we're trying to get the patient to sit in the
Better.
chair.
Don't we have to ask physical therapy, what kind of, equipment he has to use before we?
Well, that would first be determined by the doctor, but we're just talking about us as nurses to do a safe activity, okay? We need to assess, so I'm just putting little thoughts in your head, all of the different things you need to think about. So does your patient understand, and is your patient gonna be cooperative?
Yeah.
Okay, because cooperation is key. So look at B. How can tubes, IV lines, incisions, and medical equipment affect the patient positioning procedure? Let's look at tubes. What are we gonna do with tubes? What if there's ancillary tubes or IV lines?
Or catheter.
Take it off, protect it.
We gotta protect it. We have to protect it.
And also if the
You
patient
can-
wearing catheter, like after the surgery, still wearing a catheter.
Yeah, we have to protect it. So in
Right.
other words, if we're gonna move our patient, we have to be mindful, oh, they got a tube here,
Right.
they got an
Make sure it
IV
stays in
here.
place.
We're not gonna just yank it and the tube comes out, right? So we have to protect the tube. What about incisions?
Make sure it's properly covered.
Make sure it's properly covered, right? Make sure it is supported. Okay, so maybe it's something that we need to
Like a
put
pillow.
like a splint or
Mhm.
something on for some kind of support.
Mhm.
What about medical equipment? Now maybe they have an IV and it's on an IV pump.
For sure to also move it
We
along
gotta
with the
move the
patient.
pole, right? So the
Yeah.
pole
Yeah,
moves
comes
with
with
the
the
fall.
patient.
patient, yeah.
Otherwise, maybe we
fall.
stretch it, the IV comes out,
Mhm.
the pole falls over, the pump is on the floor. So you're right, you know, you're all new, so you gotta, it's not just the patient, you gotta take in everything that the
Mhm.
patient might be attached to. Okay, good. C, outline the rationale for encouraging your patient to use a stand assist aid. So that might be a walker,
Kid.
crutch, cane. So what would you say? Why is the patient using this? Why are you
Because
encouraging
you want
the
them to
patient to
For
use
safety?
this? Huh?
For safety?
Safety, that's good. What's another reason?
Balance.
Balance is another, what's another reason? Huh?
Take the weight off.
Take the weight off, okay, good. What's another one?
And also, while nurse is helping them to help the nurse also, like, that's gonna be extra support.
Extra support, very good. Why else?
Well, the first step in getting better, in being active again, encouraging activity.
Okay, so independence,
Yeah,
right?
independent.
This will help you become independent,
Yeah.
okay? This will help you. So you are helping the patient to accept this piece of equipment for this period of time. I mean, they may not need it forever, but it's very useful right now. Okay, so very good. All right, excellent. And why would you stand in front of your patient before allowing him or her to stand?
So you can observe to see.
You're observing, you're
Yes.
assessing, and you're preventing falls, right? Because if the patient becomes unsteady, what would you do?
Put them back to the.
Put them back into bed, right? Put them back into bed. And finally, which instructions are vital to ensure a patient's safe transfer to sit in the chair? You're getting somebody up. What's the first thing you wanna do?
Lower the bed.
Lower the bed.
Same.
Excellent. What else do you wanna
Go
do?
close to the,
Sit them next to the edge
you
of the
stand
bed.
close to.
Well, first you wanna sit him up.
Right. For a
Just sit
couple
him
of
up.
minutes.
Yeah.
See how he's feeling about
Mm,
that,
dizzy.
right? Cause if he was reclining and you sit him up, might get a little dizzy.
Mhm.
Then after that, what do you do?
Put the chair next to the bed in the same level or.
Okay, make sure it's locked. Oh, yes.
Yeah.
Lock the bedroom.
Yes, it has to be locked. And you want to dangle your patient. Remember, you wanna get the legs and
Yeah.
swing them
Yeah.
to the side of the bed. Let him acclimate to that.
Mhm.
Then you wanna get him to move his butt towards the edge of the bed, and now the feet are flat on the
On the floor.
floor. See how we're doing it little by little by little? And then finally, if he's using a walker, you wanna make sure you're helping him stand, that he's pushing off of the bed. He's
Mhm.
not using the
Walker
walker
to
to
come up,
push,
yeah.
because the walker could, even if it's locked, it could
Mhm.
potentially slip, right? And then you would do whatever you do to get him into the chair. Good, so remember, always safety first, okay? So when you're in the nursing, facility, and, you know, they say that you can help somebody maybe sit up in the bed, or, you know, help move or transfer the patient, please do not do this on your own. You're way too new to do this. But if your clinical instructor is with you, you have a peer with you, and your clinical instructor says it's okay and she does it with you, then it's okay. I just don't want you doing it on your own, okay, without having people around you until you're very much comfortable and acclimated to the process, okay? Because we don't want anybody falling down. And you do know that unless we talk about and teach you something in the lab,
You don't do it.
you can't do it, okay? And when you do things for the first time, you do it with your instructor there. So like say for example, if we teach you about meds in a few weeks, depending on the setting, how many of you there are, your instructor may only do 2 or 3 of you at a time, and then the next week it'll be somebody else, all right? She may not be able to do all of you together, okay, because it just may be too much, all right? So don't think you can do it on your own. You have to be with your instructor, and that's for your safety as well as the patient's safety. Okay, good. All right, quickly, let's finish the second one. As an orthopedic nurse, a significant proportion of your nursing care consists of assisting patients in ambulating, transferring, and practicing physical therapy treatments to restore their mobility. What steps would you take to prevent personal injury when assisting patients to stand? So what are you gonna do for you?
Proper body mechanics.
Proper body mechanics, excellent. Which entails what? Bending at the knees. Very good.
Keeping the back straight.
Like this.
Keeping the back straight. Yes, yes. What'd you say, Rex?
Wide base.
Wide base,
base,
absolutely. Anything else? Sizing up your load.
Mm-hmm.
Do you need help? Is this something you can do by yourself? Do you need 1 assist, 2 assists, 3 assists? Right? Okay, good. And how do these things help to prevent or reduce injury? All the steps we just outlined for ourselves. How do they prevent or reduce injury? Why are we doing this, guys?
To protect ourselves from injury.
Of course, absolutely. So if you follow proper body mechanics and all of the things we suggested, you will prevent and certainly reduce your risk of becoming injured. Okay. What is C? Describe techniques that, along with using a gait belt, prevent a patient from slipping when attempting to sit in a chair. So what else can you do to prevent a patient from slipping, losing their sea legs when they're attempting to sit in a chair? Get assistance.
Right.
All right, that's part of sizing up your load, getting assistance. What else?
With the socks and grip socks.
Put what?
Grip socks.
Yeah. Put those grip socks on the patient. They don't have, firm-soled shoes.
Maybe put the feet of the chair so they can put their feet on it.
Okay, like a little stool, maybe?
You know, the chair has like those feet so they can put their feet so they don't slip.
Okay.
But you wouldn't put that on until the patient is sitting there.
They would have to be in the chair, yeah.
When they sit.
What about,
After they sit.
remember standing in front of the patient so that if they start to slip, you just ease them back into the
Push them
bed.
back here.
Ease them back into the bed. Very good.
There is
Alright.
a special
And bring it.
cushioning for patients who mostly slide from the chair. There
What's
is
that?
different type of cushioning, 6. not active
Okay,
6.
like an assistive device, yes, like a positioning device, yes, definitely. Okay, good. D, if your patient has a hemiparesis, what's a hemiparesis?
Muscle weakness.
Weakness on one
Side of the
okay?
body.
Divide that word in half. Paresis is weakness. Hemi is half. So you're weak on half of your body. So if your patient has a hemiparesis, where would you stand to assist
By the strong
patient.
side,
involved
the strong
side.
side.
You wanna stand on the affected, or the affected or weak side, because that's the side that needs the support. Okay, so if you're standing near the patient to assist them, you're standing on their weak side because you wanna support that. Okay. And what did we talk about the cane? Where do we put the cane?
The strong side.
On the strong side, very good. All right, good, you guys are good. All right, so a few quick things to know for our exam next week. Come early, not late. Okay, we're a large cohort, we got like 95 of us. Do not make us wait to start the exam because you're late. If you're late, we won't let you take the exam. So get yourself up extra early. Get up early, between 7:40, 7:45 maybe. That's a good time. You can take a deep breath, you can relax. The early bird gets the worm. You get good seating. Everybody has their spot, I try to honor spots. Some of us will be probably in this room. I'll find out the rooms and I'll figure it out. Phones will be off that day, not put on vibrate, off. Sometimes the vibration kinda makes people crazy. So be considerate of your peers, turn it off, put it away. No excessive jewelry, no smartwatches, no earpods, no talking during the exam. If you have a question, we're all there. The professors are there, IT is there. Raise your hands. We will come right over.